Sue Jones is just joining. She's just having difficulty getting into via the link.
Thank you, Ruth, for letting us know. Good morning, everybody. It's 9:30, so we will make a start. I'm going to start this morning's meeting by paying tribute to a number of members of our staff who have sadly died in the last few weeks. And after I've read out their names and described what their roles were, I'm going to have a minute's silence in respect to all those staff who've done so much for the Trust. The first is Linda Udebala. Linda was a nurse in the community team working for Sutton Health and Care. Gail Gibbs was a renal nurse. Barbara Owens, a healthcare assistant, a theatre aide in A2 and in ophthalmology. Margaret Musabuga was a renal sister. Alan Serraj, an Associate Director of Nursing for Education and Workforce Development. And finally, Artie Bart, a healthcare assistant in St Helier ED. Our thoughts and prayers are with their family, friends, and all their colleagues in the Trust. And so could you now join me in a minute's silence? Thank you. Thank you. And now move on to the formal agenda of the meeting. Formal welcome to everybody. I'm not sure that we have many members of the public and I can't actually see them, but for those of you who have been able to join us, a very warm welcome. Do we have any apologies for absence, Meg? I haven't been informed of any, or is it Barbara?
No, we don't, Gillian.
Thank you very much indeed. Any declarations of interest from anybody? Aruna.
Apologies, just to let you know, I'm doing some work for Walsall NHS Trust.
Thank you, Aruna. I suspect there's it's geographically so distant, but many thanks for nevertheless alerting us to that. And of course, that is in addition to all the others that we've declared on other occasions. Minutes of the previous meeting, which was way back in January. Everybody happy with the minutes? Derek, have you got a problem?
Just could you add my name to the list? I was there.
Oh, I'm so sorry, Derek. I do try and pay attention to that, and I don't always get it right.
I apologise. I only just noticed it this morning.
No, thank you. We will make that amendment. Subject to that amendment, are people happy to agree the minutes? Thank you. I didn't want to say very much by way of Chairman's update, save to just to tell you about a lovely event that I joined Daniel with earlier this week. Of course, it had to be done virtually, as we've all become accustomed to, but it was giving out Gold Badge Awards to members of staff who have gone that extra mile, done something very special and been nominated by patients' families or other colleagues. And it really was, despite some of the issues around doing those kind of things virtually, it was a lovely occasion. It was just very uplifting to hear about the great things our staff have been doing. And I know they've been doing a great job. They always do a great job, but over the last few months, they've gone through a particularly stressful time. But to hear of all the things that they had done, and for Daniel and I between us to be able to give them recognition and a virtual clap was a really lovely way of spending the first part of, I think it was Wednesday morning. I'm sure Daniel will talk a little bit about it in his update as well. So that kind of takes me neatly on to item 1.5 and Daniel's update. Daniel, over to you.
Thank you, Gillian. Morning. So yes, it was really fun, the Gold Badge and the Hero Awards thing. So on to my report. So the first bit focuses on well-being. So everyone can see what an enormous thing many of us have been through in the last year. So we are putting a huge focus into how do we do recovery for our staff in the next few months. And one of the things is about the benefactor who's given us so much money towards providing gourmet food, who's willing to continue it in part for next year. So I'm hoping that great food will carry on being available to our staff for another whole year. Then on something that does resemble normal, the hip fracture service, there's a league table of how do you do against providing all the best practice standards for hip fracture care. And once again, we're at the top in London and pretty near the top in the country for hip fracture services. So that's really good news. Trevor and the team have been doing an incredible amount of estates work over the last year, despite all of the COVID issues. And one of the things that's happened a couple of weeks ago was our 5th CT scanner for the trust, but the 2nd for Epsom being craned into place. I'm not quite sure the pictures do it justice, but basically this enormous CT scanner was landed in a space that was only about 10 centimeters bigger than the scanner. So it was an incredible bit of crane driving that happened there. But this will be the CT scanner for emergency patients on the Epsom site. So that will be fantastic. We've been doing a lot to ensure our staff are vaccinated and promote vaccines in general. And Debbie had the pleasure of being interviewed by Peter Andre. And actually, we ended up with all of his publicity. It's the most watched thing Epsom's and Helier has ever been part of, was his wife being vaccinated. I think she's a very good sport. We have some photos of Epsom A&E and the expansion money we were given before Christmas, and the units being craned into place. And actually, yesterday, NHS providers featured the expansion we made of the St Helier A&E with the similar money. So that's quite fun. We've had some awards for our teaching of doctors from the University of the Caribbean. We had a visit from Vin Dewaka, who's the Regional Med Director for London, who came to say thank you to lots and lots of teams for everything they had done during COVID, and that was very well received. And then I think something that I'm really proud about is we made a huge story in the Times when they came to look at Epsom, how we had turned Swelliok into a respiratory area and an ITU area. And the was a 2-page story, and I think the feedback that the Times got about what our staff had done was absolutely extraordinary, and it felt like some real recognition of the extraordinary things that people have done to ensure we have cared for all these patients with COVID. And on the how many patients we currently have in the hospital, well, in January we had 280, as James will say, and it's much, much less now. So it's feeling much more normal. I won't steal James, Ruth and Arlene's part of the conversation when they talk about COVID. That's all from me, Gillian.
Thank you, Daniel. Just check whether anyone's got any questions or comments on any of that. Can't see any hands, but I'm conscious I can't see everybody on the screen. No, okay, well, thank you very much, Daniel. Lots of good news there. Particularly pleased to know that we've got that package put together of help for staff to decompress. I think it's equally important that all of you on the executive remind each other that you've gone through a terrible time as well. And just because we can't see you in the flesh, I suspect we can't see how tired you all are. But I hope that you're making sure you apply all of those things to yourselves as well. It's not just for all it's for all the staff, not just everyone other than you guys. So that takes us on to COVID, and I've got James, Ruth and Arlene against this. So I'll go in that order if that's okay. Was that your plan, James?
Thanks, Gillian. I'll make a start, and we did discuss as a team about our well-being, and see Ruth and Sue, who are radiating energy in front of me and light, so that's all very positive. So a lot of what I'm going to say is going to overlap with what was in Daniel's update, but I'll just touch on some of the operational demand, the recovery encompassing staff, ITU, de-escalation, and recovery of the clinical services. And then I'll mention a little bit about vaccination, and then members of the team will be more than happy to take some questions about the detail. So to date, we've treated 2,917 COVID patients who, as an inpatient, across our hospitals. The second surge peaked in the second and third week of January. And at this point, as Daniel mentioned, we had 280 inpatient beds occupied by COVID positive patients. And that represents about 45% of all of the inpatient beds. There was a huge demand on our critical care. We have a baseline capacity of 13 critical care beds at St Helier and 8 higher dependency beds at Epsom. And we needed to escalate into a total of 46 beds, which included converting the elective orthopaedic centre once again at rapid pace into a high-tech intensive care unit that could accommodate up to 26 COVID positive patients. In addition to this, there's a level of care that is needed for patients who aren't quite sick enough to go on to intensive care, but they need more additional support in the form of something called non-invasive ventilation, which is high pressure oxygen delivered through a tight face mask, and that needs specialist respiratory support. And we usually have a handful of such patients receiving this therapy in a typical winter. But during the peak of the surge, we had 20 patients at St Helier and 20 patients at Epsom, and this created very significant additional demands on the medical, nursing and therapy staff. As of today, we're down to only 47 patients, but I think it's really important that we're not complacent. That is still 47 patients who are COVID positive. And the pandemic is not over, and we absolutely need to maintain our vigilance. We only have 3 COVID positive patients on our intensive cares, 2 at St Helier and 1 at Epsom. And at Epsom, we've now repatriated the elective orthopaedic centre back to the orthopaedic team, and we're back in our normal bed base for critical care. At St Helier, we are still above our bed base, but the numbers for the teams to manage are certainly much more manageable. And just to give you a flavour in terms of the volumes of patients who are now presenting to our hospitals who are COVID positive, over the past week, we've admitted 17 patients who were COVID positive as inpatients. At the peak, in the middle of January, we admitted 237 in a single week. But so it gives you a flavour that things are certainly moving in the right direction, and the hospital does feel much more manageable. We have beds available on both sites. We still do have some staff who have been redeployed out of their normal areas, and we are incredibly grateful to all of our teams and individual staff who have started to work and continue to work in slightly unfamiliar environments to them, or have had to reutilize skills that they had in the past and support intensive care, medicine, respiratory departments, and our emergency departments. We're left with a few dozen team members who are still supporting the increased bed base in our intensive care. So now our main focus is on recovery, and there are those 3 elements that I mentioned earlier. And I think overwhelmingly, our first focus, whilst maintaining safe patient services, is to recognise that our staff are exhausted, and we absolutely do need to focus on our staff recovery and recuperation. It's really important that everyone takes opportunity to have a suitable pause, rest, reflection, and that they can re-gel again as teams. And we're really focusing through March to ensure that everyone has the opportunity to take annual leave and has the opportunity to have suitable time away from the pressures that we've experienced over the past year. We're supporting, as Daniel mentioned, a whole suite of packages to support the health and well-being, and we're training our line managers in terms of ongoing stress recognition and support to team members. If there are some questions, Debbie can pick up some of the details about the support package that we're putting in place. We really do not underestimate the impact of the staff deaths and the impact that it's had on everyone working across the trust. So this wellbeing package is really important. In terms of recovery, we have to think about the recovery of individuals who have had COVID, it reinforces the importance of us working as an integrated trust and an integrated system spanning primary and community care. So we're working in partnership to develop a program of support for individuals, whether they presented to our hospitals or are in the community, who have the ongoing effects of having had COVID, the so-called long COVID. And in addition, we've worked closely with community partners to develop a virtual ward for patients recovering from COVID in the acute phase, and a system called pulse oximetry at home, where we can remotely monitor the levels of oxygen in people's blood, and working in partnership with our respiratory physicians and GPs to ensure that patients can be in their home environment but still feel safe and are being monitored. Sue will talk in more detail, if questioned, about some of the plans for how we recover our planned care activity. Unfortunately, we did have to pause a lot of surgical operations. We have maintained most of the outpatient activity through this surge, but we still have some catching up to do. It's really good news, and I think it's very symbolic, and it shows a positive note for the trust and staff and patients that the Elective Orthopaedic Centre is going to be open for business as an elective orthopaedic centre from next week. And we're planning to go up to full capacity from the week after Easter in the Elective Orthopaedic Centre, and steaming ahead with the work to build another theatre. Our clinicians have been working to ensure that we have the right clinical prioritisation of all of the patients who are waiting for an operation, so that we can ensure that we prioritise patients who have the most need for an operation at the earliest available time. And we're working very closely with our partners in South West London to ensure appropriate equity of access for all of our patients. At the same time, as I mentioned earlier, we have to maintain absolute vigilance to our infection control practices, both for our patients and for our staff. Our staff are performing their tests twice weekly, and we're reinforcing and revisiting all of our messages to keep our hospitals, both in terms of the clinical areas and non-clinical areas, safe places to work and to be treated in. And then finally, on the subject of vaccination, to date, we've vaccinated over 10,000 individuals. The focus of the hospitals in vaccinations, certainly in the early phase, was to ensure that we offered the vaccination to health workers, people who work in the hospitals, but also our colleagues from outside the acute trust and social care workers. And then we focused on ensuring that we could offer the vaccine to those individuals who are clinically most vulnerable, such as patients who are being treated for cancer or dialysis patients. Now our focus is to continue to support colleagues in primary care and the community, to offer suitable signposting for individuals, and to ensure that we play our role in terms of offering education and support to individuals who, up to date, have been slightly hesitant about accepting the offer of a vaccine. So I think I'll pause there, and we're happy to take questions as a collective group.
Thank you, James. That was very comprehensive. I'm sure there'll be questions. I've seen Richard straight away, and then Phil.
Thank you, Gillian. And James, thank you very much for the summary. Very concise and well laid out. Quick question in relation to the recovery programme, if I may. Where do we stand in relation to our backlog of long wait patients? I know from the performance discussions, the 52-week long waiters is an area for concern, but I just wondered what the statistics around the overall backlog now looks like, because I think outpatients and diagnostics had, we'd maintained reasonable momentum on that through the course of the pandemic. So I'm assuming that regrettably we've got quite a significant build up, and I just wonder whether we can wrap some numbers around that.
Yeah, so you'll see from the January report, Richard, that we had over 600 patients waiting over 52 weeks in January. This has increased in February, and we expect it to increase again. So we currently have in the region of 870. The number is currently being validated for month end. We are setting trajectories at the moment, which will allow us to develop specialty-based plans for managing these high numbers down. And I think we know that in different specialties, we will need a different amount of additional capacity to get on top of our long waiters, but there is a curve which goes up and then slowly starts tailing off. And so the specialties all know what they need to do to recover their position. Interestingly, going forward, our problem is with outpatients, not necessarily with our inpatients and people admitted for operations. So the most important thing is that we get to a position where we can see people within 6 weeks of being referred and look at different ways perhaps of managing the outpatient pathway. So although the numbers look very scary in the admitted space at the moment, we will be able to recover that position. But going forward, we need to make sure that we don't have a tidal wave coming behind us of outpatients converting to long waiting patients. So we've got a really good sight on the numbers. But it doesn't look pretty, you're right.
Thank you, Sue. Richard, is that okay? Did you need to come back on that? I think that must be no. So Phil, would you like to go next, and then Elizabeth, and then Martin?
Thank you very much, Gillian. And it's really good to see, James, that the numbers have come down relatively fast. I was just wondering whether the people still coming in with COVID, whether they are now significantly younger than those that we had before, because presumably the vaccine's taking hold, and we're seeing a different sort of, cross-section of the population. So could you just comment on that for me, please?
Thanks, Phil. I think the answer is yes. There is a significant lag phase in terms of the timing of vaccination and the impact in terms of hospital admission. But what we are starting to see is that the average age of patients coming in who are COVID positive is coming down. Having said that, there are still some individuals who are above the age of 80 who are coming in who are COVID positive. And I think it does reinforce the message that once the vaccine has clearly, I think the combination of the lockdown and the vaccine have definitely bitten in terms of the impact for us within the acute sector in the hospitals. It's really important that we maintain careful practices, as everyone has a role to play. The vaccine isn't 100% protective, but we've certainly seen fewer people over the age of 80 coming in. And when we look at new patients who are diagnosed, where another marker where we've got a particularly large group of vulnerable patients are our dialysis patients. We are still seeing our dialysis outpatients, even those who have been vaccinated, becoming COVID positive, but very few of them are sick enough now that they need a hospital admission. So I think what we're seeing is in line with what we're hearing in terms of the national messaging. We're also working with the national team that we are actively reporting any individual who is admitted more than 10 days after receiving a vaccine who's COVID positive, so that those numbers can be tracked. Otherwise, nationally, they'll only see that data much later on. So we're helping contribute to national research in that regard.
Great, thank you very much, James. Very, very interesting. Thank you.
Thank you, James. Thank you, Phil. So Elizabeth, you next.
Thank you, Gillian. Thanks, James, for the update. When we're talking about vaccinating our staff, we do include in that cohort, don't we, contractor staff, like, for instance, people who work for Mighty, who are our facilities team. And I'd like you to confirm that. And I'd also just like to remind everyone that Epsom and St Helier did have a role in the clinical trials for the vaccine, and that we were part of that process originally.
So I'll hand over to Debbie in terms of the specific vaccination question, but you're absolutely right, Elizabeth, in terms of our contribution to research. One of the biggest studies and most important studies in terms of COVID is the recovery trial. And we have been one of the leading recruiters in the country. So this is the study that has demonstrated that hydroxychloroquine didn't offer benefit to patients, despite lots of noise about that and certain high-profile individuals feeling that it was an important treatment to have. It's the study that demonstrated that dexamethasone saved lives, and it's also the study that showed that the drug tocilizumab saves lives and reduces the needs for patients to go to intensive care or ultimately end up on dialysis. So we're really pleased to have been a major national contributor in that study. We also were a very major participant in a vaccine trial with Novavax, which is likely to come online for the population later this year. But I'll hand over to Debbie in terms of the details of vaccination.
Thank you, James. Yes, I can confirm that we provided the vaccine to all our workers on site, including our outsourced services with Mighty and security, plus all our contractors. So all the contractors that were, even our building contractors who are on site at present, we provided vaccinations for them as well. We also provided it to all our agency workers and our bank workers.
I just wanted to thank James for that roundup and to say that we really, well, I will really look forward when further information is available to hearing the results of that research, James. It's very, very important work.
Thank you, Elizabeth. I've got Martin and then Aruna, and then I think we'll draw this to a close. Martin.
I just wanted to first of all add my endorsement on the extraordinary efforts of our staff and the outstanding leadership that the exec has shown through this period. There was quite a lot at one point around medical students and nursing students breaking off their training to work in hospitals, and I'm just conscious I haven't known anything about that for a while. I assume that it's not so much the case now. But in terms of all our wellbeing work, I'm conscious through other work I do with the university sector that those people are going back to a far from normal situation where the normal support isn't there. And I'm not sure if we're able to, even if they're not with us directly anymore, whether or not we're able to offer any support to those who might have been particularly affected given their own lack of experience and education at that point.
I'll pick up the medical students, and Arlene might want to talk about the nursing side. So the medical students that we have within the trust are students at St George's University Hospitals, and the medical school there largely coordinates their pastoral care. A relatively small number of medical students were supporting us within the acute trust during the second surge. We had a few more in the first surge, but we have been providing the same input in terms of pastoral care for the medical students whilst they've been with us, and linking in with the medical school in terms of recognising individuals who might have been under particular stress and ensuring that their support was offered through the medical school. I'll hand over to Ali.
Hi, yes, thanks, James. Similarly for nursing, there were different categories of nursing depending on what program they were on, and some in the first wave, some of our students were allowed to go on to the temporary register, so they were able to work as registered nurses if they were in their final year. That temporary register closed and then it reopened again, but with different conditions. So we have supported our students and they were given the choice to either work as unregistered healthcare professionals and be paid and forfeit their learning time, or to continue as students. And most of our students continue to be students, so they continue to work as alongside their registered colleagues and maintain their hours for their for their program. So we've had a mix of that. We were fortunate as well, and because we took many more students, because places were not that readily available, we were given additional funding to put in practice development support for them to ensure that they continue to have the support that they needed during the pandemic.
Thank you, Arlene. Is that okay, Martin? Okay, great. And Aruna.
Yes, I mean, again, to say thank you for such a clear update and for all the work that everybody is doing and your teams are doing. I just wanted to ask, well, firstly, I wanted to assure that we did have a report. We spoke about long waiters to ensure that there was no harm on long waiters, and we were, James brought the process that Sylvia's put together to ensure and assure us that no patient is coming to harm. So I think that that's important to note, that even though there are 870 patients waiting 52 weeks, no one has come to harm. And I think that that's important. But the question really I wanted to ask was, there's a lot of noise about wave 3. Are we preparing for that? Are we part of that process? And what are we doing, and what is our thoughts around that?
Okay, I'll pick up the harm bit, and then I think Sue was going to make a comment about any potential future surges. I think it's likely that we're going to move into an endemic phase rather than a pandemic phase, but Sue can give you the details on that. So there's been a very detailed piece of work looking at patients on the waiting list, on every single waiting list that we have in the trust waiting for surgery. There's a helpful national scheme for determining clinical prioritization. On top of that, our teams are using a matrix that is not just being too binary about defining the nature of the operation. It's also taking into account individual patient factors such as pain or psychological effects of the long wait in terms of supporting the prioritization process. I feel very confident that our clinical teams working with the admin teams have reviewed, continue to review, and keep in touch with individuals who are experiencing difficulty whilst they're on the waiting list.
James. Aruna, in terms of a third wave, the feeling is that there will be a third wave probably post-autumn, before November, but we don't know what that's going to look like. I don't think any of us expected the second wave to be quite as difficult as it has been. I was with our emergency planning team yesterday, and they're currently preparing a debrief of what we've just been through in the second wave. That will be bottom up and top down. So we'll go right across the organisation, and by just probably after Easter, we'll have a series of meetings to look at what we need to put in place for a third wave should it arrive, to make sure that we are well, if not, and probably better prepared. So we'll be able to highlight where things have been particularly tricky. And I think we need to do some work around redeployment to make sure we're slick with our redeployment, and then even slicker with getting people back to their base area of work. But there will be several areas that we'll pick up. But that piece of work is in train currently.
Thank you, Sue. Thank you, Aruna, for the question. And thanks to all the executives who's contributed to to answering all those questions. That's, I think, been most helpful. So we're asked to note, well, there isn't a report, but I think we'll note the update that we've just received. So thank you for that. And moving on to 2.2, the subcommittee report, starting with Patient Safety and Quality Committee. Aruna, are you going to kick off, or Derek?
Yes. So as everybody knows, this committee is co-chaired by Derek and myself, and we've decided to take it in turns to present at board. Derek did it at the last public board meeting, so I will do it this time. We have 2 PSQ meetings, one on the 29th of January and one on the 26th of February, both shortened, of course, because of COVID pressures. And I'll go through what we've been through. So the first thing we went through, of course, was the COVID operational update and phase 3 recovery. I won't touch on that because we've had a very detailed dialogue about that. The only thing I would add really is the success story on the oxygen supply. So thank you to Trevor and the team, and we're up and running, and just to report that from the last time we met. We were presented the quality report and the update from Q4 for the quality report. Of course, as expected, we didn't make as much progress as we would have liked to given COVID, but the really good news is we have firmed up on all our priorities for next year, and these have been actually signed off by all our stakeholders. And I think of note is that nosocomial infections is one of our key priorities, and also we agreed to put KPIs related to antimicrobial stewardship. The other thing to note as well in terms of our priorities is in terms of the learning from deaths, we are going to add in a review of learning disability mortality review into all our learning from deaths. So substantial assurance on that, and we look forward to the new priorities and how we take those forward. Maternity update. We had an update, a CNST submission. As most people will know, there are 10 priorities related to CNST, or 10 indicators. It's fair to say there are a couple that we are struggling to meet, again, because of the COVID pressures. In particular, there's an expectation that 90% of our staff will be trained in emergency procedures. Again, given COVID, there have been pressures in terms of achieving that. But by and large, I mean, I think it's a great achievement to have met all the other targets. In terms of the Ockenden report, we've submitted everything we needed to submit from NHSIE. And actually, of particular good news, the Trust are now able to restart home births, and partners are now able to attend scans. We had a couple of presentations, actually, one from the Medical Examiner Service. This was established in our Trust in August 2020. Sally Lewis, who is the lead on this, came to PSQ and gave us a presentation of the good work that the medical examiners in our Trust are doing. Very reassuring that medical records of deaths in the hospital are reviewed by them, and actually that I think very reassuring in times like this that they are available, make themselves available really to family, and to be able to talk to the bereaved in terms of their loss. We also had a presentation from End of Life, again, very timely given the situation we are in. Very reassuring. They have and continue to be good rated across the Trust. I think the key takeaway from that was really more collaborative working with our community services, and Chris has been particularly helpful in terms of helping us connect the dots there. So thank you, Chris, on that. And we had community representation at the End of Life meetings. I will add one more thing there, which wasn't at PSQ, but also just I think is of particular note and comfort, really, and assurance to the board. We do have an ethics committee that was stood up, and we plan to continue to keep it going forward, and there are terms of reference being drawn up for it. So I think both Chris and Derek attend the ethics committee as well. In terms of infection prevention and control, as I said previously, it is one of our quality objectives. It is work in progress. It's one of our quality objectives. We have had a number of risk assessments done in terms of moving forward. We continue to audit. We have seen, of course, an increase in infections, and we are very aware that the antibiotic prescriptions have gone up during COVID. But as I said, it is work in progress. I think the one thing to bear in mind, our estates are always going to be a challenge, but it's fair to say, given it's a priority for us next year, we are working hard on it, and we're really all over it and very, very aware of it. In terms of regular reports to PSQ, again, as we've said before, COVID pressures has meant that we've been really focused on what matters, making sure our quality reports are up to date, that there's no harm to patients, etc. So the standard reports have been slightly affected by that, but I think the IPR is now back on track. We can see it in our reports aboard, and I think that's it. If anyone has any questions.
Thank you, Aruna. I can't. Oh, Derek, I was going to say, did you want to add anything?
Just to endorse everything Aruna said, and just to pick up, infection control has been a big thing for us. And I really just wanted to note the hard work that Arlene and her team and many others have done. It's such a huge challenge in the current context, and they've worked really hard to make this to make our estate as safe as possible for patients coming through. And we've put that down as a work in progress because there is so much challenge in this area, but just wanted to acknowledge publicly the hard work that Arlene and her team have put in.
Thank you, Derek. I think that's very helpful because there is an enormous amount of work and much success, but the estate works against us, as we all understand. Elizabeth.
I was only going to add to what Aruna said about the oxygen supply. It was an enormously complex piece of work that required so many parts of the hospital to work together, and it has been truly a game changer in the care that we have been able to supply to people since that came on stream, and to thank everyone who was part of that.
Thank you, Elizabeth. Oh, Aruna, did you want to come back?
Yes, just one more thing that I didn't mention, and I think I should mention because it's important from an Akendon point of view. I have attended now 3, is that right, Ruth? 3 maternity get-togethers, and I have to say the energy and enthusiasm and Ruth's ability to solve things so quickly for them is remarkable. So I feel very, very assured that we're really on top of things there, and the staff morale is improving, and and they know that they have somewhere to go.
Thank you very much indeed, Aruna, for that. Of course, they've got the benefit of both Ruth and Arlene, haven't they? But it's very, very good news to hear that. Thank you. I can't see any other hands, so I'm going to ask Gord to note that report and move on to people, culture and equality. And that's you, Martin.
Yes, thanks. So I'll keep it brief, but happy to take any questions. So just by way of a reminder, so this is the combination of what was the Equalities, Diversity and Inclusion Committee and the People and Organisation Development Committee. And during this time, there was one meeting of each. So starting with the one which focused on the previous pod issues, what we decided to do was on each of them, I'd left it up to the exec, so to Debbie and Arlene on whether or not, given the pressures at that time, we had the meeting at all, or what the agendas should be and the length of it. So their decision was for the pod type one was that we should just concentrate entirely on COVID issues. Within that, a lot's already been said about the well-being, which was one of the key things which was discussed. What I'd just add to that is that one of the specific things that we recognise needs to be done, and now is being done, is that we need a diagnostic tool, because clearly not everyone is the same, and there needs to be and there's lots of stuff available to for an individual to go in and do some diagnostics on their own situation. And then the other thing is that obviously we know that it isn't the case that those who most need help are necessarily likely to recognise they need help or to speak out. And a lot of the cultural work that we've been doing will help to build that it's okay to ask for help. We also focused on the vaccine programme for staff, and obviously that's a moving feast. And you'll see in the report there's some differences between the two meetings. But at that meeting, one of the particular areas of focus was the proportion amongst the frontline staff who've been vaccinated, and particularly within that, at that point, in nursing and midwifery. And the message was that although it was lower than we would have liked, it was in line with, or perhaps ahead of other trusts, and at that point was rapidly improving. And then on the meeting, which focused more on equalities and diversity, obviously we picked up that same issue again, and the very well known but very concerning, relatively low impact from this group of staff who were classified as BAME. And there was a huge amount of work being done on that. And a lot also being done by the networks, which was very encouraging. So a lot of the activity in that meeting is coming directly from the staff who volunteer their time as part of the networks, and including on this issue. I'll leave it there and happy to take any questions.
Thank you, Martin. I can't see any hands at the moment, so maybe I'll nip in if I may. How are we doing on the staff vaccination, Martin? What's the current feeling? Because there's quite a lot of pressure nationally, for reasons we entirely understand and indeed support, that we really get these numbers up, particularly amongst BAME staff. And I know there's been a huge amount of activity. Do we think we're making the right kind of progress?
Well, the numbers when we had these meetings were increasing rapidly. I haven't seen any numbers since, so it's probably best if Debbie could just update us.
Yes, I can confirm that our BAME uptake is now 66%. And actually this week we decided to particularly focus on encouraging those who have not taken up the offer of vaccination to have a conversation with the team of vaccinators or occupational health team or student speak up guardians or any trusted colleague. And we've also said that we need to understand what their vaccine hesitancy is. But since that conversation, or since that message in our trust bulletin, as well as direct emails to the individuals, we've had quite a few come back to confirm that they were thinking about it and now they're happy to receive it. And some who has particularly spoken to Arlene around asking particularly for the AZ vaccine, which again we are organising with our Helier Floyd, our medical director for community. So we'll be providing a special clinic for those who have requested that vaccine.
Maybe I could just add to that. I guess it's more of a national issue, but in my view, there's a lot of really good stuff, which the behavioural science, behavioural economics, and nudge, some of you may know it as, which is very relevant to this. And clearly, on what Debbie was just talking about, there's a big difference between somebody who has a very firm view that they are not going to take the vaccine, and somebody whose behaviour you're trying to influence because they're not sure, they just kind of haven't got round to it. So I really welcome that update with that sort of work will help.
Indeed, it sounds most encouraging. Arlene, was there anything you wanted to add? No requirement to. I just wondered if, since your name had been mentioned in dispatches, whether you wanted to add anything.
No, I think it would just to say that there is quite a big conversation going on around particularly our BAME staff, and we have engaged with our REACH network, which is our own staff network, and they've clearly identified that some staff will prefer to have AstraZeneca. And we're sorting that out. But I think this whole thing around hesitancy is a big issue as well, with the preference for staff confidence instead of hesitance. So it's how we build staff confidence as opposed to how we reach hesitant people.
Thank you, Arlene. Well, I'm encouraged by what you've all said. And Daniel, you wanted to come in here.
So there is a link between the staff survey and the results and the vaccination uptake results. So 40% of our staff are from BAME backgrounds, which is about slightly above average for London, but clearly a lot above average for the rest of the country. So in the staff survey results that came out yesterday, I'm really pleased that we have the highest score we've ever had for equality, diversity, and inclusion from our staff about feeling this is a good place to work, and the highest score in South West London. And I think that degree of engagement is reflected in the uptake we have for BAME staff for the vaccine is a lot higher than many other trusts in London. So the focus we've had on making Epsom and Helier an inclusive and diverse place, I think, is beginning to actually show some dividends in engagement levels and then things that we collectively think are important, like staff vaccination. But that's not to say we're resting on our laurels, because 66% for the vaccination rate is still way too low. For the whole trust, it's at just over 3/4, which is much more in line with top quartile performance for trust staff vaccination rates across the country. So thought that context was helpful.
It's very helpful. Thank you, Daniel. And I am encouraged. I know that this is a difficult area, but you're clearly working really hard at it. And I'm grateful for that. Any other points on Martin's report? Otherwise, could we note it and move on to Finance and Performance Committee? Richard.
Thank you, Gillian. So this report covers 2 meetings, January and February. I'm not going to dwell on performance because I think we've probably spoken at length around that. So I will focus on finance. And my comments are basically grouped around 4 headings. Firstly, in terms of the ongoing financial performance against plan, people will recall that the top-up regime ended at the end of September. And so we've been on a sort of a temporary quasi-block contract regime since then. The current estimates are that we would be somewhere between £6 and £7 million ahead or favourable against the plan for the balance of the current year. That's basically due to, I think, 2 principal reasons. One, because the expenditure relating to the recovery plan hasn't been incurred because of the second wave. And secondly, because we haven't been able to fill all vacancies and staffing levels have been below where we might have previously hoped or anticipated, we spent less on staff costs. The second thing I'll comment on is capital program. As of the end of the February discussion, the Trust is still forecasting to spend approximately £70 million of capital for the full year. As of the February update, we were some £15 million behind where we should have been at that point in the year. So we'd spent £45 million of that. We spent some considerable time reviewing the capital program and the mitigations that were in place to recover that. And I think we took a high degree of assurance that the restart of various programs and the committed expenditure that the Trust has entered into left us with relatively small risk of underspending that capital budget by the end of the year. Third area I'm going to talk about briefly is planning for next year. And Rakesh gave us a first flush view of what the current guidance is for next year. And perhaps there's an update on that Rakesh might want to comment on. But the anticipation at that stage was that the first quarter of next year will be something of an extension of the current arrangements, but that as we move from quarter two for the rest of next year, we will return to some sort of pre-COVID arrangement with CCG contracts, some additional recovery funding, and the return of CIP programs to try and begin to look again at efficiencies. Very early stages in planning, so not a lot to really comment on in detail there. And I think the fourth point I'll just flag is that we reviewed I think it was 3 principal business case approvals. The first was heads of terms for the 4-trust pathology program. The second was an extension to the existing contract for our staff bank services. That extension then would put us in step and aligned with our fellow South West London partners, which would allow a review of that program in future. And then finally, a contract for a continuation of our security services arrangements. I think that's probably about it. I'll leave it there unless there are any questions or if Rakesh wanted to comment any further.
Thank you, Richard. That was really clear and helpful. Rakesh, anything you wanted to add?
No, thanks, Gillian. No, I think that was very comprehensive.
Okay. Any questions from anyone? Can't see any hands. Could I just ask whether we're still confident about the capital spend? I don't know whether that's you, Rakesh, or Trevor, or some kind of double act.
So we're just finalising the numbers for the end of February, and we'll do that in the next couple of days. So we may be slightly behind plan, but we're just finalising these numbers. I don't have anything to update the board on at this stage, unfortunately, otherwise it'd be misleading.
Okay, thank you, Rakesh. No other points? So can we note that report, please? And then move on to 22D, which is Sutton Health and Care and Surrey Downs Health and Care. And that's Chris, who's momentarily disappeared from my screen, but the minute he talks, he will appear, I know. Chris.
There we are, I will appear, hopefully for you. Thank you very much. So the report is divided into 3 sections. One is sort of generic for both Surrey Downs and Sutton area. The second is specific issues around Sutton Health and Care, and the third is specific issues for Surrey Downs Health and Care. And in terms of what was generic to both of them, which, you know, one would expect that because they're delivering very similar services to pretty similar but not identical populations. And I think what I just wanted to highlight was that, of course, just as the acute services had to wind down planned care, so did community services. But during that time, planned care patients still had access to advice and information, even if their treatment specifically couldn't be put forward. And there was a response to the COVID surge, which is highlighted in the report. I'd highlighted several things to mention. I was delighted really to hear James talk about them. I think it must be a real sign of the integration that's going on in our area, that we have the Joint Medical Director of an acute trust discussing services that are being delivered in the community, specifically here around virtual wards and pulse oximetry. So had we been meeting together, you would have noticed me punch the air to celebrate this. So those are indeed true, and the aim of that is to support patients in the community and to also support the acute trust in allowing prompt discharge of patients who can be managed in a way that would not hitherto have happened. The other thing I just wanted to pick out was the provision of rapid response to providing support for care homes. One reads in the press and on television and so on about the woes of care homes. I would say that our community services have made great effort through dedicated support teams to support care homes clinically, and I suppose in terms of morale, in knowing that they're not isolated. And indeed, a survey of care homes in Sutton undertaken by Healthwatch recently showed that they had felt very supported through both surges, in fact, but including the most recent one. So that's good news, and congratulations to those teams. Moving on, the community services have been involved with the mass vaccination programme, particularly around housebound patients and in care homes. And that's gone really well, with vast majority of patients being vaccinated. Usually where vaccination hasn't been taken place, it's because the individual is right at the end of their life and it's felt not appropriate. I would also like to mention again, because you read about it somewhat negatively in the press, locally, the community teams and the in primary care services have been providing vaccinations to those who are homeless and to learning disability at home. So we've had a good coverage of those residents, which is really good, showing how, sort of ahead of the curve in many ways. The importance about going forward, we've talked about staff well-being, and that's just as true in the community, with people repurposing their workloads, and what's available for staff to work purely in the acute trust is also available for those who work in the community. James has already mentioned the long COVID response. These are patients who have prolonged symptoms, and there's a mixture here of sort of STP-led work, particularly in Southwest London, but also what's happening locally, not waiting for guidance from on high, but getting on and trying to deliver services and build services for this group of patients who will be significant going forward. Specifically within Sutton Health and Care, the key issues we're looking at and trying to replace some of the IT system, moving from Rio for community staff to EMIS, which will allow a lot more integration across the acute trust, primary care services and the community services. And the one thing as we all know, in a sense, is that people find troublesome is that patients had a service delivered by the NHS in one place and they can't find out what it was because we can't link up. So that's going to be a good benefit when it comes through. This is a process that we hope to start in Sutton, but has already taken place in Surrey Downs. Like a lot of IT setups, there were some initial teethings problems, but that has now come to fruition and is working well locally. Within Surrey Downs, I think the thing I wanted to highlight was the decision by Surrey Heartlands ICS not to commission the CCOL Centre at Headley Court beyond March, the end of this month now, this year, and because the feeling is that need will not be that great, and some need can be met elsewhere at other existing premises. And I would really like to call the board's attention and thank them to everyone who's worked there, whatever their role, but particularly three people who, to use the phrase, made it happen and have kept it happening. And that is Rakesh Patel, our Chief Finance Officer, Thurza Sawtell, Director of Integration, and Dr. Hilary Floyd, who was the Medical Director for the CCOL Centre. So I think if you're agreeable, Chair, I would like to hopefully note that in our minutes. The final thing I wanted to just raise is for the board note, the progression of Surrey Downs Integrated Care Partnership organisational development work. This is part of the direction of travel towards the development of places integrated care places within integrated care systems. I apologise for all these names. And certainly in the Surrey Downs area that this is progressing at a pace. That's all I wish to mention. I'm happy to take any questions or comments if you wish, Chair.
Thank you, Chris. That was great. I thought your point about James talking seamlessly about community was so well made. And also SEQL. I'm conscious that some board members haven't even had the opportunity to see SEQL because it opened when we were already in the first wave of the pandemic. But it is a fantastic facility. And in the last couple of weeks, if any board member wanted to see it, I hope we would be able to enable them to do that, because I mean, I just thought it was such a fabulous facility, and okay, it's no longer needed, but when I think how hard you all worked to make it happen, and what a great job you did, also points that you've made, Chris, so thank you for that. I can't see any hands. No? Okay, so we're asked to note, oh sorry, Daniel.
So I just thought we should say on SEQL that unlike most of the Nightingales, it did treat a lot of patients. So over 350 patients have had rehabilitation at SEQL over the months it's been open, and the patient satisfaction is really high. So it has been a good thing.
It has indeed, Daniel, and it's just such a lovely facility in such a delightful spot. But there we go. The decision's made, and I guess it's one less thing for the executive to worry about. So that takes us on to item 2.3 in the integrated performance report. Very pleased to see it. I'm just going to go through my usual list of executives, see if they want to particularly highlight anything to us, starting with you, Ruth.
Thank you very much. So I think just to highlight that, as we already heard referenced, the crude mortality rate in January was higher than in previous years. And you can see here that that rate is still higher than you would normally see in February, but has reduced quite significantly, as was borne out in the more detailed presentation earlier on. The other point I think to make is that despite the pandemic, we have continued with our process of mortality review and actually have been able to complete, using redeployed and shielding staff, a reasonably high proportion of reviews, either by level 1 methodology or the more detailed structured judgment review. And that has continued to provide invaluable learning and insight, more of which later. I'm not going to go into the COVID data because I think we've discussed that in some detail, but I think it's important to note that this level of analysis here is something we've been reviewing on a weekly basis, enabling us to pick up trends at a very early stage in order to plan patient care optimally. And that's all I was going to pick up. Thank you.
Thank you, Ruth. That's very helpful. Many thanks. Arlene, anything that you need to particularly highlight for us?
Sorry, no, I think it is as is in the report, only to say that there are some additional pages that we intend to ensure that make it back into the IPR. So we are continuing to work behind the scenes to get this up and complete, because we have lost some of the pages.
Thank you, Arlene. Rakesh, anything?
No, I think Richard covered it. So we are, since summer, we're ahead of plan at the end of month 10. The forecast remains we will hit our target and be slightly ahead of it. Capital forecast remains challenging, but we'll get the latest numbers. No, and nothing beyond that. Thank you, Gillian.
Thank you, Rakesh. Well, it's a jolly good position to be in, is what I think. It's always nice when you hear those kind of things described by your CFO. Debbie, anything that you needed to highlight for us from the performance report?
Just a couple of areas, please, Chair. One is the vacancy rates. Whilst we can see a slight downward trend in our metric here, we're still above our KPI. We do have our Be More campaign continuing, and also the chief nurses team are working with direct recruitment in terms of bulk recruitment of nurses and healthcare assistants. So I'm hoping to see some positive movement in that metric. We've talked about sickness absence and well-being, so I won't mention that. And the other area is around appraisals, which we hope to begin again with a focused piece of work in Q1.
Thank you, Debbie. The appraisal level is clearly not where we want it, but it's absolutely understandable in all the circumstances. I suppose it's quite amazing that the figure is as it is, actually. Sue, was there anything that you wanted to flag up for us?
Just 2 or 3 points. The cancer position is from December, and the January position looks less favourable, just to warn people, because we've had issues with staff shielding sickness, and so that the performance going forward will be more compromised, but there is a recovery plan in place. For Plan K, you can see the steep drop in the admitted pathway, and that's because we closed 4 theatres and also all of Swelliok. Our recovery plan starts properly on the 6th of April, so we'll see that improving over time. Outpatients and diagnostics, we've tried to maintain as much activity as we can without compromising the need for staff in ITU, so less of an issue to try and recover those, apart from the backlog, of course. We've talked about 52-week waits, and for A&E, you can see there our performance is 74.9%. I'm pleased to report we're back up to over 90% now, and the really good news is that throughout COVID, the wave 2 of COVID, all of our estates work continued on both sites, and we've now almost completed the improvement works to our ED department, so we're in a much better place to continue over the coming year.
Thank you, Sue, that's great. Thurza, I'm very conscious that I forgot to ask you after Chris's report whether there was anything you needed to add. My apologies, but I just give you the opportunity now.
No, that's fine. It's very comprehensive. Thank you.
Okay, thank you, Thurza. Sorry, I didn't do it in a timely manner. I've seen Martin's hand.
Yeah, a while ago there was an issue where people with cancer were presenting relatively late due to sort of general reluctance to see doctors. Has that got back to more normality, or is that still an issue?
So Martin, we still have experienced a reduction in referrals on the 2-week rule pathway. We've decided to work in partnership with the other acute trusts in Southwest London to do a detailed in-depth review as to what's happening and to see what impact this has had on the population. And I think there are 2 main areas that we want to look at and support the audit in. The first is to look at the stage of cancer when it's diagnosed and to see if that has changed. And secondly, to see if we're getting a higher proportion of patients presenting to us through the emergency route rather than through the usual outpatient route. And I think both of those are really important exercises to undertake so that we can understand whether there's been harm and what lessons we've got in terms of future communication with people if sadly there's another surge in the future.
Thank you.
Derek?
Yeah, thanks. Can I just flag up the hand hygiene numbers, which are really encouraging for February, 99% with 95% submission compliance. We've been very concerned about this at PSQ, not because we had data that things were bad, but because we were missing data on whether they were good or bad. But that February data has come through since the last PSQ, and that's very reassuring. So just wanted to flag that up as a good practice point and an achievement. So thank you.
Absolutely right, Derek. When I saw it, I thought we could have put reasonable assurance rather than work in progress on the quality report. But if we'd had that information, yeah.
Can I just add, we didn't have that information when we wrote the report. So.
Exactly. And when I saw it, I thought, that's good to know. So thanks, Derek, for emphasising that. I can't see any other hands. So if we could note that report, please, and that takes us on to the corporate risk register. And that's you, Peter.
Thank you, Gillian. So there are just 3 points to note around the corporate risk register. two of which we've already talked about. So the completion of the oxygen supplies back in January has now come off the risk register because that's now satisfactorily in place and has been commented on elsewhere in the meeting. Similarly, our financial position is now pretty much crystallised for the year, so that risk has come down. And then the third point is that we will be refreshing all of the risks as we transition from year end in March into the start of the next. So there's further work to be done to kind of make sure we cleanse the detail in the risk register, but the main headlines in the risk register remain as they are because many of the risks are long-standing.
Thank you, Peter. Chris.
Thank you. Yeah, it's a risk 2.1 regarding cardiology services. I note that it's for review this month, and maybe I should raise this point next month, depending on what the outcome of that review is. Do you know, Peter, if a review will take place this month, or has it been put on hold because of COVID and so on? The reason I ask is that it's concerning, and I suppose my experience in the GP in the past has noticed that, the complexity of the pathways around cardiology for patients attending certainly St Helier, and it'd be nice to have some confidence that that's going to get straightened out in the near future, but maybe we need to wait till next month if there is indeed going to be a review this month. Thank you.
Okay, perhaps I'll clarify a process point. The review we're undertaking is basically, has anything changed? Is there anything material, as opposed to a review of the particular nature of how we're going to solve it. But perhaps I'd ask James to comment on the cardiology one.
Okay. So I think you're right, Chris. It's an important one that we can't take our eyes off. The pathway is incredibly complicated. Two bits of assurance I can give you in terms of what's happened during the surge. Firstly, in terms of intensive care transfers, one of the historic delays has been appropriate transfer of patients requiring cardiology input. I think one of the big pieces of learning through the surge has been the strengthening of clinical networks across Southwest London, and we've got quite a good functioning critical care network now. And I don't think we've experienced any delay in transfers of patients from critical care to critical care. The second bit of reassurance is that I attend a London-wide clinical prioritisation meeting, and Southwest London, there's a new way of prioritising patients. Pre-COVID, we used to list patients either as urgent or routine. Now we have a little bit more granularity, and we identify the most urgent patients according to a prioritisation scheme P1 to P4. And there's a bit of concern that patients who are in the P2 category, so the second most urgent category across London, don't yet have the theatre. There isn't the theatre capacity to manage all of these patients. Southwest London are reporting that for patients within our catchment population, which would include the Epsom catchment population, no patients have died on the waiting list who have been identified as P2, whereas pre-COVID, patients who were listed urgent, some of these patients did sadly die on the waiting list. So there's been an enhanced clinical prioritisation about patients who are waiting for definitive surgery. But the point you're picking up in terms of the cardiology medical intervention, we still need to continue to do ongoing work with.
Thank you.
Thank you very much, James. I can't see any other hands, so we're asked to endorse the proposed changes to the risks within the corporate risk register. So I'll assume that you're all up for that, unless anyone shouts now. Okay, that's good. Now, so we move on to item 2.5, the Freedom to Speak Up update report. And I hope Moira, our Freedom to Speak Up guardian, is here. I did see her name at one point. Are you still there, Moira?
Yes, I'm here. Thank you.
Over to you.
Okay, well, thank you for the invitation to come today. There is a report included within the papers, which I'm hoping that we can just take as read. And there were just a few other little things that I just thought I would highlight. Obviously, when lockdown ends, our priority is to try and get out and about a bit around the trust and within the communities, because we are very much a service that benefits from being out and meeting staff. We now have a total of 14 advocates. We've got another 2 colleagues who are considering applying to join us. We consider that the advocates are adding real value to what we do. Sometimes they signpost staff to us, sometimes they refer cases straight to us rather than signposting elsewhere, and sometimes they lead on cases. They are promoting the raise and concern culture within their own teams and areas. We are pleased with the ethnic diversity of the advocates, as broadly speaking, I think it mirrors the trust, but we are a bit women heavy. So we are always encouraging colleagues to consider applying to be an advocate and join us. A COVID casualty for us has been the raising concerns policy, which is overdue for review. And we have done a lot of work on that recently, but have just been informed by the National Guardian's Office that we should hold fire on that, as national guidance will be due out probably in the next 3 months or so. So we're just going to put that back on the back burner. One of the themes that has come through to us from last year has been about managing fairly, or maybe more accurately, staff perceiving that there are occasions when it feels that their line management is unfair. And so we're working with the OD team on producing training to address specifically this need. And I also think that this is going to link in closely with some of the results which I've just seen have coming through from the NHS staff survey. In terms of bringing the cogs together, which I referred to in the paper, we are looking at the NHS staff survey. They talk about 10 specific themes. We don't record our data in this kind of way, so we're going to review what we do and see if we can marry up with the way that the NHS staff survey does its results, in order that that there's greater correlation between what we do. We think this will be a huge step forward for us. If we can do it, we'll start that from the 1st of April. And we're currently changing our data collection system to reflect the financial year rather than the calendar year, which is what we've done previously. On a final note, we're just finalising our 7th newsletter, which we hope will be ready to go out to staff next week. And we just had a tiny weeny space that we needed to fill it in with some little tidbit of something. And just through chatting, we realised that out of the 6 last cases that have come to us most recently, all 6 of those have come through as word of mouth recommendations. So for us, we obviously feel that this is a really bit of good news for us, and I just thought I'd like to share that with you. And also to thank so many people across the staff. We get an awful lot of support from really, very senior people in terms of real time and real commitment to us, helping us to develop the service. And I would name them, but my fear is I forget somebody. So if I could just do a general thank you. People have been really supportive to us.
Thank you, Moira. That is so good to hear. And I must say, I love the 2 cogs in the report. I thought it was a lovely way of making the point. So I can see Chris's hand and then Aruna's.
Thank you very much. Thank you for the report, which was good to read. I just wanted to ask and I've forgotten the name, the supporters that you have for freedom to speak up, your 15 or so people, could you just say something about the spread across the trust? Do they reach all the way across, or are they sort of aggregated in 1 or 2 areas? Thank you.
I think the spread is pretty good. I mean, needless to say, it could be better. We have a guardian who has a day a week in Surrey Downs Health and Care, and she works quite she links in with us, but she's quite independent. We have an advocate in Sutton Health and Care, but to be honest with you, we need more out in the communities. We realise that that's an area that we need to develop. We have a very good range of people in the sense that we have an advocate in the finance team. We have somebody down in ED. It's not just really local people or not just people that we know. We have a spread across different teams and in different areas. Our latest person who's joined us has come from estate and facilities. So I think that we are getting we are getting a spread. We could always be spread more widely. That's for sure.
Thank you for that.
Aruna.
Yes,
and then Derek.
Yeah, to acknowledge all the work that Moira and her team are doing. It is really stellar work. And I think to acknowledge actually, I was at the oversight, the Freedom to Speak Up Guardian oversight meeting, and was my first one chairing it. And I have to say, the group of people around the table are all enablers, and I feel very reassured that the things that we raise are taken away and actioned on, and lots of support from Rakesh, holding the purse strings, giving us the Epsom office, I think, fantastic, and I think a lot of support to Moira really from Rakesh's perspective. So I was very, very reassured, whatever you want to call it, by being at that meeting and seeing the energy and enthusiasm, in terms of wanting to take this forward.
Thank you, Arun. That's very good to hear. Derek and then Debbie. Debbie, did you want to come in before Derek, or is it all right to go in that order? Yeah, so Derek and then Debbie.
Thanks, Maura. I just think this is really important. And I guess one of the things I'm feeling through this is the sense in which we normalize speaking up. Yeah. And, that it doesn't become something extraordinary you do. I mean, that's one good thing about moving away from the term whistleblower, I think, because a whistleblower feels like something exceptional. Speaking up feels like something normal. And I was interested in your comment that you're seeing more routine inquiries, and that perhaps tells me that maybe this is becoming more normalized, as these are people to go to the FTSU service. But my question was for you, is there a way of capturing how difficult people find it to speak up? I mean, I noticed your sort of feedback questions here, and I expect there are more, but I was wondering if we can catch up how, it's a question like, how difficult was it for you to approach the service? I don't know, trying to capture how much courage does it take to speak up, because we want to set that bar as low as possible. I mean, we don't want every inquiry about everything. We don't want people asking you, how do I fund the coffee shop? But, we want to trivialize it, but on the other hand, we want to normalize it, don't we? So my question is, how do we capture that?
I think that's a great question, actually, because one of the other changes that we're making is to our survey questions. And again, we'll be changing those from the 1st of April. We're tweaking them. We can add that as an additional question in. I think one of the pieces of work that we're doing is trying to understand some of the data that we got from last year in terms of the themes that were raised to us. And one of the questions that we think is that an awful lot of people who come to us, they leave. Now, whether they leave because they've chosen, they're moved within the trust, or that they actually physically leave, my gut instinct is that a surprising number of people actually leave the trust. And I think that suggests that it takes people, or traditionally it's taken people an awful long time to come to us, that if they could come to us sooner, perhaps we wouldn't get into the position that so often I think that we end up in. And I think that these kind of chats that people are phoning up about, that we're getting more recently, again, I don't know whether they're a COVID consequence, that people are just needing somewhere to download. But it's not really that. It's not really that they're phoning up, but they're phoning up to talk through their options. What could they do? What might they do? And it is very much a confidential conversation, just a download or a sounding board, and then they go off. And whether they choose to come back to us or not, or what they choose to do, is entirely up to them. But I think that probably does suggest that we are becoming more normalised. And I think the number of people who come to us as word of mouth recommendations, I think, does suggest that. But we can certainly add that question in. It's really good timing, because our survey questions will be changing on the 1st of April, so we can add that question in from then.
Yeah, maybe think about the form of words. I didn't quite get it right. No. That's just what came to me.
Yeah.
Thank you, Moira. Thank you, Derek. Debbie.
Thank you, Chair. I just want to say that one of the areas that we've done really well in our staff survey this year is the fact that staff perceive that as an organisation we act fairly in regards to career progression and promotion, regardless of ethnic background or any other protected characteristic. And I know that that's been an area that the Freedom to Speak Up team have really focused hard on working with myself and other colleagues around addressing. So I just want to showcase and endorse that as a testament of some of the great work that the team have done. Thank you.
Thank you, Debbie. That's very good to hear. I can't see any other hands, so we're asked to note the report. And Moira, thank you very much for joining us to present the report. It's really good when it'd be nice to see you in the flesh, you know, when we're all back in a room together. But thank you very much indeed for attending the meeting to present your report. Right, so that takes us on 2.6 and the Guardian of Safe Working. And James, you're presenting this on behalf of the Guardian?
I am, Gillian, yes. So I think, first of all, it's important to note that this report is written, and it's by Andrew Combier, who's our Guardian of Safe Working Practice. And it is his report, and it's independent of the executive team. But unfortunately, he's not able to make the meeting today. I have been in communication with him, and I think I won't be misrepresenting his thoughts. I think we should acknowledge that this role is incredibly important, both in terms of safety netting for trainees, but also triangulation of information about where we potentially don't get things right all the time. So the report highlights that during the surges of COVID, there's been a reduction in reports from trainees. We experienced that in the first surge, and we've seen a similar thing in the second surge. And then we've started to see, as we've de-escalated, an increase again, which has largely related to reports about trainees working beyond their contracted hours, and those issues have been able to be resolved. I think it's really important to recognise that our trainees were really engaged in terms of planning for the surges. They understood the need to contribute, and they really did want to contribute to providing safe care, and were incredibly flexible in their approach. I think we've learned a lot from the first surge, and the trainees helped to co-design the COVID rotas and support each other during redeployment. Unlike Moira, I am going to thank certain individuals. I think we need to acknowledge the ongoing work and commitment that Andrew Combier has given to supporting and advocating on behalf of the trainees. Richard Bogle as the DME, Director of Medical Education, and the postgrad team. And one of Richard's comments was that it was pleasing to see that we've had very few concerns from trainees about a lack of educational opportunities, even during the surges. So it's good to see that our clinical supervisors took every opportunity to continue to use normal practice as educational opportunities, even if there were fewer conventional lectures and teaching opportunities. So our trainees did feel that they managed to continue to access suitable education and training, despite being in unfamiliar environments. And I also want to thank Jalpa Katecha, who's our Chief Registrar, who helps to coordinate and lead on behalf of the trainees. And then finally, I think I should highlight that one of the important components of exception reporting is where trainees feel that there may be a safety concern. Those safety concerns are noted in the report. And I think it was good to see that there was good engagement from the clinical supervisors, and in particular the clinical directors and divisional medical directors, to ensure that the trainees felt that they could continue to deliver safe care despite staffing levels being stretched, particularly in some of our high pressure areas such as the respiratory ward. So it's good to see that our teams have responded to the concerns that the trainees have raised. I'll pause there. Thank you, Julia.
Thank you very much indeed, James, both for your thorough introduction, but also the thorough report. And Andrew's just not able to be here today. He will come to subsequent meetings, I hope.
Absolutely, yes.
Yeah, okay. So any questions for James? Can't see any hands. Oh, Aruna.
This is very comprehensive, actually, James. Thank you very much. And actually very reassuring to see that things are being dealt with. I have just one question. Of these exception reports, there's 16 altogether that have taken particularly long, are still open as of January 2021. Any insight into what particular area that is? I can see the breakdown by grade, but is it medicine? Is it mainly medicine, or is it across the board?
So Aruna, I'll have to get back to you on the nature of those specific 16, but as you can see, the vast majority of exception reports occur within medicine, and it's largely because that's where the bulk of the trainees are, but it's also where most trainees were redeployed to support the acute services. My suspicion is that they'll be related to hours worked, but I'll get back and look at the details of those individual 16.
Thank you.
Thank you to Aruna and James. I can't see any other hands, so could I draw you to the what the board is asked to do, actually at the back of the report, because it's slightly more comprehensive at the back of the report. It includes that we note that the immediate safety concerns were being raised. So if we could agree that as set out there, that's the only difference. It's just a small point, but I think it's important that we include that in our formal minute. Is that okay? Lovely, thank you very much. So that takes us on to 7, learning from deaths. Ruth, I think that's you.
It is, thanks very much. So I'm presenting here the learning from deaths update for Q3 that was referenced and considered earlier at the Patient Safety and Quality Committee. As you're aware, we bring this regularly to the board, to the public board, for sharing and for noting. Some key points to note, because this is a very comprehensive paper. We have continued through Q3 to undertake mortality reviews, particularly focusing on the more detailed structured judgment reviews. We've used a number of staff who haven't been able to work clinically to keep those reviews underway. And we are confident that the information from those reviews optimises the changes that we can actually subsequently make to patient care. I think 92% of reviews were completed during this period. The data from those reviews shows that in 58% of cases the care was good, but also highlights that there were 4 cases in the quarter where the care was poor overall. Now, all of those cases then get noted as a clinical incident on Datex and are subject to further review and evaluation. I think if you look further at the detail and the themes that emerge, end-of-life care features as an area of concern in some of the cases reviewed, with a number of ratings there being attributed as either poor or very poor. What's important to note there is that the reviewers have found that when referred to the end-of-life care team, patients get an excellent service. The issues there are about noting and escalating the patients nearing the end of life at an earlier stage. And that is a theme that we're addressing and discussed in some detail at PSQ. Other themes and learning that we're taking forward from this are that in surgery, we think clinical care would benefit from having input from a medical doctor trained in the care of older people, rather like the way we have for our fractured neck of femur patients. And the proposal to take forward a business case for that post is now being progressed, in part as a consequence of this review process. Aruna has flagged up the need to focus more heavily on the deaths in patients who have learning disability. And we've also picked up some specific issues around field administration. Important also to note that as well as picking up areas where we can further enhance care, we do actually pick up areas where care is really good. And consistently, when they weren't redeployed, the input from the outreach nursing team has been really well valued and has made a very significant step change, I think, in patient care. And we've also picked up some very positive comments and improvements in patient note keeping, which has actually been as a result of the focus we've put in place for training staff as a result of earlier concerns that were noted during the structured judgment review. So I think we're really starting to see maturity from the reviews that are taking place and a real impact on patient care. The other things to note, I think, from this report are that our HSMR for the period was stable at 95.45. And I think the final point to note is that we reference in this the embedding of the medical examiner service, which was alluded to in the PSQ feedback. The service is a statutory responsibility. It is independent to the trust and is staffed by both trust clinicians and clinicians who work elsewhere as GPs. And actually, we have at times been able to review 80 to 100% of deaths through that service. And I think we are increasingly seeing how important and how well received it is by the families who've been recently bereaved, to have a very early contact from someone in the trust and to have confidence that their loved one's death is being reviewed by someone independent to those who deliver clinical care. So I'll end there. I'm very happy to take any questions.
Thank you, Ruth. That was very helpful and comprehensive. And of course, we were able to have a good debate on both this report and the medical examiner service at Quality Committee. Martin.
Yeah, it was on the medical examiner. It's not because I think there's a problem, but I just wondered what going forwards, what we were thinking about in terms of medical examiners and whether or not there was a report to the board, because it seems to me the principles, the thinking behind it are similar in some ways to freedom to speak up and guardian of safe working.
I think that's a really important point, Martin, and actually for that reason, Derek and Aruna had asked Sally Lewis to come and talk to PSQ with some of the early reflections and learning from the service. And I think the anticipation is that she will bring a regular report, and actually that report will start to be more quantitative as well as qualitative, in order to really give us confidence that the service is doing what it was set up to deliver. It's important also to note that that service will in the next year start to be required to review all deaths, including those that occur outside of a hospital setting. So the role of the service will change and will broaden over the coming 12 months.
Thank you.
Okay, I can't see any other hands, so can we note that report and move on the agenda to item 3.1, contracts awarded over £50,000. Rakesh.
This report's been to the Finance and Performance Committee, and just here for noting, Gillian.
Thank you very much. We're happy to do that, I'm sure. And 3.2, use of the trust seal. Trevor.
Thank you, Chair. This is just obviously for information that as part of an outstanding matter to close down some obligations of the trust for the land disposal with Guild Living, that we've released the condition around the electrical supply.
Thank you, Trevor. Board happy to note that report? Yes. I haven't been notified of any other business. I'm assuming that there is not. Our next public board meeting is Friday the 14th of May. And that brings us to the end of the meeting, but we do have some written questions which have been submitted, which I think, Daniel, you're going to deal with.
I'm going to deal with most of them, but Peter is going to do the first one. They're all from Sandra Ash. So here we go. Peter, do you want to do the first one?
So I'll read out the question for transparency as well as the answer. So first question was about the videos. Can you tell me why the video of the last meeting on the 8th of January has yet to be published? It's now the 10th of March. When will it be published, and when will this meeting's video for the 12th of March be available to the public on our website? So the answer is the Zoom recording of the meeting was corrupted and does not prove possible to upload a video of the meeting to the website. However, a full set of minutes was taken that are available with the papers on the website. The video of today's meeting will be available on the website in the week commencing the 15th of March. So that's the first question.
Thank you, Peter. Right, over to you now, Daniel.
Here we go with question 2, called misleading information. This is the expensively produced illustrations of Epsom as a district hospital and St Helier as a district hospital used at all Improving Healthcare Together public consultation events, which were endorsed and attended by Epsom and St Helier Trust, show large buildings which occupy a significant proportion of the proposed provision labelled acute inpatient services. A, given the IHT plan is to remove all acute care from both Epsom and St Helier, can you explain what these buildings are? B, why were they included in all the consultation presentations to the public if there is and was no intention to provide acute inpatient services at either site? Answer. The information provided in the consultation was correct. Both St Helier and Epsom hospitals will continue to have inpatient beds for patients who are on an emergency care pathway, and at Epsom for planned care patients. Question 3, finances. During the public consultation, we, the public, were told repeatedly there were no circumstances which could increase the cost of the IHT proposal. Can you give us an update on the current financial position regarding the provision of the proposed acute facilities co-located with the Royal Marsden and the planned refurbishment of Epsom and St Helier's remaining buildings? It has been said by many that the costs are set to increase significantly. Will you have enough, or will you have to A, go back to the government to ask for more money, B, provide less, C, abandon IHT and take up the cheaper option of upgrading Epsom St Helier hospitals and retaining both as acute hospitals with at least the current number of general and acute beds? Answer. It is correct that the cost of the hospital facilities that we are proposing has increased. This is primarily in response to the learning from COVID. So, for example, we were proposing to have 50% of the bedrooms to be single ensuite. Now we believe this figure should be 70%. This will cost more money, but we would have applied this learning to all the options that were consulted on. The increase in cost because of COVID is common to all of the new hospitals that the government is planning to build. Our business case is currently being assured by NHS England, NHS Improvement and the Department of Health, and we should know the outcome in May. And lastly, a question about bed numbers. During the public consultation, it was said that we have 1,048 general acute beds at Epsom and St Helier. Can you please tell us how many general acute beds we have at Epsom and St Helier Trust? My answer is there's no change to the bed numbers compared to the consultation document. There we go. All the questions.
Thank you very much indeed to Peter and Daniel, and thank you very much for the questions. So that brings our proceedings to an end, and we have another private meeting afterwards, but I suggest we aim to be back by 11:30 if people can do that. Is that okay? I can see a lot of nods. Will it? And a thumbs up. Thank you, Chris. Peter, will that work technologically?
Yes, if we exit this meeting and follow the links to the new meeting.
To the next one, but at 11:30 rather than the 11:45, which was on the agenda. Yeah. Okay, lovely. So thank you very much, everybody. Thank you to the members of the public who joined us. And I will see board members in about just under 10 minutes. Thank you all. Bye-bye.